If we could imagine that we could instantaneously test all of the globe at once and know the results, what we would find is that there is that we have only discovered the tip of an iceberg, but that the vast majority of what is out there is either asymptomatic combined with the low symptomatic or minimally symptomatic and mildly ill disease.
Steve, thank you so much for joining us today.
Thank you, Robert. I'm glad to be able to be here. Thank you for giving me the opportunity to chat with you.
I know you are very busy and have a new post. Please tell us about it.
Yeah, so my day job before COVID-19 is I'm with the Family Medicine Residency Program through John A. Burns, and I have recently been asked to take on the role of coordinating the public health and medical services aspects of the response effort for the State Emergency Operations Center.
So what aspects of the crisis response are you not then responsible for?
So that's a very good question. Actually, crisis response is extremely complex, and because particularly something of this scale touches every aspect of our society, we have learned to tie in and integrate different essential functions into the overall response. It uses what's called an incident command structure that helps us organize into functional aspects how you address an emergency or crisis or disaster. Within that are these what are called emergency support functions. So that might be transportation, it might be safety and security, it might be fire. Those are called ESF functions, emergency support functions. So I am the lead for the state ESF 8, which is the public health and medical services aspect.
From my perspective, it's been quite amazing how quickly and robustly governments around the world have taken quite radical action. On the other hand, most governments, despite pretty bold action across the board, have taken action behind the virus. What are your top priorities to try to be one of the fortunate places that gets ahead of it?
I think here in Hawaii, we already have some fortunate things in our favor. So one is just the geographic location on the planet, and that this is a epidemic or now pandemic process that started in China and fortunately for us decided to make its way westward through Europe and across the globe. And we really are going to be one of the last places of sizable population where it's going to land upon our shores. And it has already, obviously. But we had lead time that other places around the globe did not have. And what that allowed us to do was take some lessons learned from some of these other places around the world and apply them here in a way that has definitely had an impact. We're seeing data already that we have, in fact, flattened the curve, as many folks have learned about. Yes, the disease is still circulating and growing, and we'll see, larger numbers over time, but at a significantly slower rate.
I mean, Hawaii has caught up. The U.S. has been behind many other OECD countries in terms of testing, but the U.S. has caught up. Hawaii is doing pretty well, I think, in terms of per capita testing. But do you feel like there is enough kind of population representative and asymptomatic testing to have a very accurate sense of where we might be now as opposed to where we were 2 weeks ago?
The short answer is that testing in and of itself doesn't magically save lives just because you test somebody, because this is a disease process where there is not a curative medication or vaccination, at least not substantially proven yet.
Right.
And so, but what testing does get us is a better understanding of what the disease is doing in the community and how to focus our intervention efforts. Now, if we could imagine that we could instantaneously test all of the globe at once and know the results, what we would find is that there is that we have only discovered the tip of an iceberg, but that the vast majority of what is out there is either asymptomatic combined with the low symptomatic or minimally symptomatic and mildly ill disease. That's why in countries that have done a tremendous amount of testing, relatively speaking, so if you look at, for example, Iceland, where close to 4% of the population has been tested, the case fatality rate plummets because you're testing deeper and deeper into that asymptomatic and mildly symptomatic population. When your resources are very limited and all you can test are the really critically ill people, then you find that your case fatality rate is going to be high because you're testing the sickest of the sick.
What at present is keeping Hawaii from having the capacity to do, say, epidemiological testing, representative population testing?
We are doing epidemiologic testing, not to the degree that we would like to be doing. And we have stood up a surveillance program with several hundred tests being done on that surveillance network, and that's increasing. We have to realize that this is not a disaster that is local, but it truly is global. So the entire global supply chain, swabs, as you mentioned, media, sometimes just being able to stand up the facilities quickly enough, all of those limiting factors have been challenges that have impacted this area.
Well, another question I have, since I've been talking to epidemiologists and they love data, has to do with the granularity of data. So we've been in the US fairly sparing with the data that we maybe compile, I guess could be part of it because it takes time, and the data that we release. My concern is, for instance, if we don't know ethnicity, then we might not see that, say, Native Hawaiians are getting hit harder, like now the new data is showing quite starkly on the continent with African Americans. What's your vision for sharing data specificity and collection as we build up testing capacity?
So I do think that unintended consequences are an issue that have to be taken very seriously. So there are lots of legal precedents and laws on the books that allow us to do a lot of things in the midst of a public health crisis that we might not do otherwise in terms of balancing privacy rights and individual rights versus the societal good. However, we have to be very cautious about how those are implemented because the downstream effects can be tremendous. There is a way to get sufficient granularity to get at things like ethnicity and populational level data and subpopulations without necessarily pinning a scarlet letter on somebody. If we're, for example, there's lots of talk of using apps, and that is very, very useful from an epidemiologic point of view and can help us get control of the disease in some ways, or at least in terms of flattening the curve. However, how closely are we vetting the app makers, and where's that data going, and who has the rights to it? We know that we are highly susceptible as human beings to having our emotive buttons pushed manipulatively through media in a way that changes behaviors that can affect society. So again, careful balancing of these very complex, challenging issues.
I want to ask another question that will come back to this privacy concern, and that's contact tracing. There are old-fashioned ways to do it, which are very personnel intensive. So my first question is, how will we build the personnel capacity to do really in-depth, old-fashioned contact tracing? And two, what are ways quickly, without the regular vetting process, that we could move toward hopefully partially anonymous cell phone tracking data or credit card transaction data or a voluntarily downloaded app, big data contact tracing to supplement the old-fashioned gumshoe type?
Yeah, so I think there are opportunities for us to leverage technology, certainly, but at the same time, there is real value in the tried and true careful methods and finding that right balance. The other concept that I think is really important, so as a physician who provides care, if you are in a disaster kind of setting where the resources are extremely limited vis-a-vis the need, we sometimes have to adjust the level of care that we provide. And so you sometimes lower your standard of care, carefully keeping it at the absolute best that you can manage. But we can also do the same with things like contact tracing. So we may not need, the pages and pages and pages of contact tracing, but we can get in medicine, we used to actually handwrite prescriptions. I remember those days. And there was something called a quantum sufficient. So just enough. So we get just enough data to be able to effectively do the contact tracing for control purposes of isolation and quarantine decisions, and identifying where the disease is spread. But there are other things we can do, like anonymous social network mapping, so that we can find where the social nodes are, and you can come up with benign interventions that can be very effective in that particular space.
Some estimates I read suggested that ideally you would have one employee doing contact tracing for every 4 cases, which would suggest we'd need to hire like hundreds of people. How many people do you think we do need to hire, and can we do it fast enough? Should the National Guard be used? What are ways to move that up? Our testing has gone up, but our contact tracing, I'm just guessing, would be hard to be keeping pace.
One thing is how you focus your contact tracing matters. So contact tracing, particularly around clusters of outbreak. But to answer your question, one of the consequential upsides, if there are some, to shutting down the economy is you have lots of fallow labor source. In disasters and crises, people come together in a way with a volunteerism spirit and a let's get through this spirit that is truly inspirational. And so we have amazing self-organizing groups of healthcare workers, of public health students, of all kinds of resources in the community that are eager to get engaged in this in this endeavor to really bring things under control.
Are you operating in a resource scarce environment?
Well, we actually probably have everything we need, more than we think we do. So overall, we have significant resources available. And I think we have adequate resources to do this well, especially here in Hawaii, because as I said, we do have more time, and we are seeing, as I said, evidence that we're flattening the curve. And so that buys us some more time to really hardwire some of these interventive pieces from a public health perspective and really flesh them out.
Yeah, well, another one of those resources that has tragically / magically materialized are thousands upon thousands of empty hotel rooms.
Yes, absolutely
And
correct.
because we live in an island state with elevated housing prices, we therefore have, one of the highest rates of intergenerational households in the country, as well as pretty elevated housing density.
Yes.
If we send people back who test positive, even if they're asymptomatic, to live in the house with grandma, there's a lot of intra-household transmission that could take place. Like, are there plans afoot to take advantage of that individualizable housing for quarantine?
Absolutely. And there are already contracted hotels on several of the islands, and contract negotiations are going forward with other hotels as we speak, really. It's a win-win situation where the private sector hotel industry and hospitality industry that is hurting so badly out of this crisis can recoup some revenue and income and help support their staff. So it really adds capacitance and relief in multiple ways.
One of the things I worry about is just the terribly tragic, very high rates of death that we're seeing in nursing homes around the country. Are there ways to leverage our hotel capacity to help with that crunch? Obviously, moving people out who require full-time care won't work, but what is our hope for, arresting those places that really become not just hot zones, but death zones?
Absolutely. One of the keys to a successful response here is to, as I like to say, we need to bubble wrap our vulnerable populations in 3 layers of bubble wrap, while at the same time delivering goods and services to them so that they can do that securely and safely with the appropriate supports. Because again, those vulnerabilities put them at risk for other things. So, if that's a kapuna who has some memory issues, who's used to getting their food out in the community, and they now go home and try to cook for themselves and leave the stove on and burn down their house. And if, oh, by the way, they're in a public housing unit, you could have more mortality in a single day than you would have out of the entire event. In terms of utilization of non-congregate housing, i.e. hotels or other facilities being stood up to decompress some of the more congested spaces where our most vulnerable and at-risk population is, absolutely that makes sense. But having the buy-in of our corporate partners in the community is going to be really key, and making sure that they understand really the relatively low risks to them as a facility and as an organization, and that they can really utilize this as a way to show commitment to the community and connection with the community and be leveraged into, positive messaging is really important.
Even more challenging in that respect is, building the support and figuring out how to do housing for at-risk congregating populations that are less popular than, say, first responders, people without homes,
Sure.
misdemeanants who are being released from OCCC. How far behind do you think we are in preventing quite, severe clusters of infection in those at-risk communities?
Yeah, so what this really brings out is that the social determinants of health drive the vast majority of morbidity and mortality in our society every day. The impacts of COVID-19 go far beyond the morbidity and mortality associated with the virus. So we do have to pay very close attention to these most vulnerable and at-risk portions of the population who also are at risk for being a site where the disease spreads very easily. And it's actually very interesting. In most disasters, you can map the death toll or the death rate directly on top of the socioeconomic level. So absolutely, you're right. We have to have very good planning in place to take care of those populations. But it really gets back to, again, the fact that we don't, as a society, do a good job of taking care of these populations to begin with. So, to try and fix it in the middle of a crisis makes it a little challenging, but it also gives us, yet again, another opportunity to turn crisis into opportunity to fix some of these structural elements that put all of us at risk. And that's what people often don't tend to see, is if you don't take care of the least of these in society, you put everyone else at risk.
Right. We should talk for a moment, not just about this pandemic, but pandemics and public health crises just over the horizon. In the US in particular, among wealthy countries, we've done a great job of investing huge resources in military readiness. We've clearly not done as good of a job in public health readiness, and public health departments across the country have experienced pretty substantial cuts in recent years. In your estimation, what would it look like, say, 3 years, 5 years, maybe even 10 years from now, to have a really fully robust, well-funded public health infrastructure that a wealthy country deserves?
So, I think one of the things is to recognize the inherent value of thinking about, and this is particularly difficult for, I think, Western European and American culture, to think about the good of the whole as being critical for the thriving of the individual. Structurally, what that looks like, again, is being willing to give up a little bit of the me first approach that we sometimes take, and focus resources, and yes, the fiscal resources are what really drives a lot of the outcome here. There is no us and them in this world anymore. It is a few hours from Wuhan to Rome, and it is a few hours from Rome to New York. And we are such a small world now because of technology. Things that make for robust public health are surveillance, particularly in the infectious disease world. Creating one of the real challenges in public health in terms of under-resourcing and underfunding is the infrastructure support in terms of data management, data gathering, computers. What's happening at Google and Apple in terms of the technology they have access to makes what happens in most health departments look like the Stone Age. So let's leverage those abilities. Let's provide those resources to the public health sector. That's the kind of thing that really gets us much further down the road.
I think it's very easy to get caught up in the crisis and talk about ventilators and N95 masks, but a lot of people are afraid, a lot of people are ill and isolated, a lot of people who kind of most need our social connections. To what extent do you think that safeguarding the emotional well-being of our society can be part of the crisis response?
It's absolutely critical. How a community comes through a crisis it's a matter of resiliency. And resiliency begins in the individual with how they frame what is being experienced. So one of the things that I'm trying to do internally here is flip the script. We are not talking about social distancing. We're talking about socially connecting in an age of physical spacing. People are dying in hospitals without the value of human touch, without seeing the faces of the people who've been caring for them for weeks, and without family members being able to be present at the bedside. And that's a tremendous tragedy and loss. And so positive messaging, realizing that every single one of us is a response partner in this, and that this is about ohana and our kuleana to our community and to our islands and to the world at large. In every major disaster, it's not the big government that saves the day. So in an earthquake, who saves the most lives? It's not the USAR teams that are flown in from afar. It is the neighbors who dig neighbors out.
Right.
And that's really where we are right now.